All right, guys. So let's talk today about EKG, the basics. So I've had several students reach out to me asking for an overview of EKG, which I actually happen to teach in my program. So it all made sense. Why not make a lecture for you guys as well? So let's talk a little bit about EKG. And again, this is just the basic. Guys, this is the tip of the iceberg. So when it comes to EKGs, practice, practice, practice. No one's perfect at them. There's always a little room for interpretation when it comes to some EKGs. The biggest thing as it relates to nursing school and as it relates to your future licensure boards, like the NCLEX exam that you take at the end of all of this, it is all about identifying life-threatening emergencies, which we are not going into in this video, okay? There will be a separate video for more advanced EKG practices, but being able to recognize when something is not right, and then the appropriate interventions are always like the biggest thing to know about it. So let's talk a little bit about the foundation of EKGs. You may see two different terms. You may see EKG, you may see ECG. These are both the exact same thing. It's a picture of the electrical conduction or the electrical activity of the heart. So what's interesting about the heart is the heart has two distinct systems. It has a conduction system, which is what we are going to talk about here, which is what the EKG looks like. And it has a muscular component, which is the physical beating of the heart. What is also interesting about the heart, I could go on for days about all the lovely things that it does, but for purposes of time, what's also interesting is that your heart can still have that conduction. It can still have those nerve impulses. You can have a almost beautiful looking EKG, but the heart not be pumping at all, which is really kind of freaky if you think about it, which means if I have a patient hooked to a monitor, I can still show electrical activity of the heart, even though it is not physically beating. How crazy is that? So let's talk a little bit about the conduction system. We have to have some foundation, some definitions here, as with anything else. But polarized means there's no electrical activities. The cardiac or the heart cells are at rest. Nothing is happening. The term depolarization is a stimulation of the muscles in order for them to contract. Repolarization means the cells return to that resting state. We have our primary pacemaker of the heart, which is called the sinoatrial node, or SA node for short. That's actually found on the higher surface of the right atrium. Again, it's the primary pacemaker of the heart. This is where in a normal beating heart, guys, remember we're only talking about normal heart rhythms here. In a normal situation, this is where the heartbeat starts. This is the very start of that electrical impulse into the heart. And so what you'll notice is that it impulses at a rate of 60 to 100 beats per minute. And notice how that's the normal adult heart rate, because that is what we anticipate in a normal situation. From the SA node, the electrical impulse will then travel through the left and right atria. The atria will contract in order to push that blood out of those atria into those ventricles. And then what we find is that that impulse will stop at what's called the atrioventricular node, or AV node. And when I talk about these conductions or how this impulse travels to the heart, it seems like a long drawn out process, but you got to remember a heartbeat is that fast. Snap of your fingers, that's a heartbeat. So even though it says that the impulse stops, it is a very brief stop, like hair split second stop. So the AV node is located on the atrial septal wall. So that's that wall that separates the atria from the ventricles. The impulse will slow down. That allows the ventricles to fill with blood, because remember, the atria just contracted to push the blood. And so for a very brief second, the ventricles get to fill with blood. Now, the interesting thing about the AV node is it has its own ability to fire an impulse, okay? This is not important when it comes to the normal pathophysiology of the heart, which is what we're talking about, but this becomes extremely important when we have an abnormality of the heart, which would be the next phase of this video series, if you will, for EKGs. And it has its own pacing ability at about 40 to 60 beats per minute. Okay, so very slow. And what's also very nice about the AV node is that it will only initiate if it has not received the impulse from the atria. So if there is some sort of delay, is some sort of problem between the atria and the ventricles, that's why the AV node picks up, because it has to pump that blood out of the ventricles. All right, once it leaves the AV node, it's actually going to then do a couple of different things. Okay, so the impulse is going to go through the ventricles through what's called the bundle of His or His. Neither is wrong because you can see how it's spelled. The second thing it's going to do, it's either going to go to the left bundle branch or it's going to go to the right bundle branch. And so the left bundle branch sends nerves to, you guessed it, the left ventricle. Okay. The right bundle branch goes to the right ventricle. Okay. Once those, the impulse has gone through those branches, it will then go to number 3, which are the Purkinje fibers. These Purkinje fibers are located very deep within that muscle tissue of the heart, also called the myocardial tissue. This can also be a pacemaker, but as you see, our rate of impulses go down further and further and further. So this is where we get in some of those heart rhythms that people are having conduction issues, might be in heart failure, might be in heart block. You notice that a lot of these things have a very slow pulse rate. And so you can see, even if our SA node at the very beginning is not firing like it should, there are other places where an impulse can fire. So when we get down to the Purkinje fibers, we're talking only about 20 to 40 times per minute. And again, we'll only fire if the previous 2 electrical areas, so the SA node and the AV node, it will only fire if those 2 do not do their job. So this is just a picture for you so you can kind of get a visual of what everything that I've talked about. Here we have pointed out the SA node. This is where the electrical impulses start. They move down to the AV node. Here's our bundle of His, and it moves down into the right and left bundle branch blocks that further go down into the Purkinje fibers. Then I've also put the picture over here so you can see as it relates to what you're going to see on your EKG. And we will go into more detail on this, but the P wave is that atrial contraction right here. Okay. There's a PR segment, which is that time from the atria contracting until the AV node begins to fire. Then we have what we call the QRS complex, and the QRS complex actually is when the ventricles are doing their thing. They're in their jam doing what they need to do. Then we move to the ST segment, and that's where those cells are kind of resetting, trying to start all over again, moving into the T, which is right before we move into another heartbeat. All right, here it is again for you guys, okay? So the P, this is how we're going to measure when we talk about our EKGs. We have a P wave that we're going to look at. We have a PR interval that we need to measure. We have a QRS complex that we need to measure. Sometimes you'll see people measuring the ST segment. We can if we want to, but the T is the other kind of thing that we need to watch for. Now, you may say, well, there's a U wave that's popped up here, and how do I know what's what? So a U wave is not always seen, okay? The U wave only shows its head when it wants to. In most EKGs, you actually don't even see a U wave. So we won't go into too much detail because, again, this is the very basics. This is normal EKG recognition. So let's talk about our P wave here. So it is the very small wave that comes right before the QRS. Now, a lot of students ask me, well, it's rounded or it looks a little flat or it's peaked, like in the picture here. It does not matter, guys. The only purpose of this is that your P waves are the exact same, okay? No P waves, like my P waves are different from your P waves. But the point is, when you're looking at an EKG rhythm strip or several of these complexes, we want to see that that P wave is the same. So when we get down to interpretation, maybe it'll make a little more sense. Now, again, this is that atrial depolarization, or when they contract. And this happens when the SA node fires an impulse into the heart. Now, we do have some norms. So when we get into EKG interpretation, we have some normal values that we would expect. And one of the things that we expect is we expect the P wave to be 0.06 to 0.12 seconds. So extremely fast. Next we have is the PR interval, and this is measured from the start of the P wave to the end of the PR segment, or just before the QRS begins. This represents the time for atrial depolarization, so this is the completion of that contraction. It accounts for that impulse delay that we talked about, and it allows that impulse to now travel to the Purkinje fibers. This one's a little bit longer. The time is usually 0.12 to 0.20 seconds. Next, we move into the QR complex. The QRS complex is measured from the start of the Q wave, which is right through here, right where it downward flex, to the end of the S wave, which again is another change in direction of your waveform. This is ventricular depolarization. So this is when our ventricles begin to contract. Normal time, guys, even faster here, 0.04 to 0.12 seconds. Next, we move to the ST segment. That is measured at the end of this S wave of the QRS complex, and it's to the start of the T wave. This represents very early ventricle repolarization. Remember, that's that rest or returning to a rest and relaxation state. It is usually flat, which is also called isoelectric, same as the PR segment. Next, we move into the T wave that follows the ST segment. It represents ventricular repolarization. So again, it's complete rest and relaxation for the ventricles. It's typically rounded and usually asymmetrical. As you look at this waveform here, you can see that the peak is shifted slightly off to the right. So midline would be right where the T comes down. You can see that it has just a slight shift over to the right. Then we have the QT interval. A lot of times this is not necessary, but in some of the more advanced heart conversations that we'll have a little later on, the QT interval becomes important. Now that's the measure from the start of the Q wave to the end of the T wave. It represents for total time. Remember, the ST segment is early ventricular depolarization. The T wave is full ventricular depolarization, and so the the QT segment all the way across is going to be complete ventricular depolarization. This should measure about 0.36 to 0.44 or less than half of the R to R duration, which makes no sense because we only have one R here. So I'll show you that in a minute. Right here is where I talk about R to R. So R to R would be this wave to this wave, this wave to this wave, okay? Our EKG paper or ECG paper, doesn't matter what you want to call it, is printed on graph paper. It's measured in time horizontally left to right. They have tiny, tiny, tiny blocks, okay? So here at the very end, this block looks pretty big, but it's only because it's enlarged from this that's been enlarged from this. So when I talk about a small block, I'm talking about right through here. Let's see if I can annotate here. This right here is one small block. One small block right there. Everybody see that? I hope you can. 5 small blocks are 20 seconds. So this is 1, 2, 3, 4, 5, or 0.2 seconds. I'm sorry. So 1, 2, 3, 4, 5 are 0.2 seconds. All I did was I took the small block time of 0.04, multiply it times 5 because there's 5 in each little block, and you get 0.20 seconds. Now, what do we do when we multiply that times 5? We get 1 second. So 1, 2, 3, sorry for the jacked up 3, 4, 5. That's going to be 1 second of time right there. And then 30 of these large blocks are going to be 6 seconds of time. And where that comes into importance is that, oops, that's not what I wanted to do. Becomes important because when we analyze rhythm strips, we do it in a block of 6 seconds. So we do a 6-second time snap to do any EKG interpretation. So that's why I include the 30 large blocks of being 6 seconds. All right, so let's get down to the nitty gritty now that we've gone over the foundational stuff, and that's how do we analyze this rhythm. We have 8 primary steps that we want to do, okay? We're even going to cut that down a little bit more to about the first 5 steps when we're talking about basic interpretation. Because again, when we get into the ST segments, the T waves, the QT intervals, et cetera, we start talking about more advanced cardiac concepts. And that's outside of what I want to talk about. I really want to just get down to, how do I look at this rhythm, tell me if it's okay, and if it's not okay, then I go to the advanced things. So the primary things that we need to focus on are going to be determining the heart rate, determining if it's regular or irregular, and I'll show you how to do that, examining the P wave, measuring the PR interval, measuring the QRS duration, and again, 6, 7, and 8 can be included, but those are more advanced outside of what we want to talk about. So determine the heart rate. We have a couple of different ways. Number one, again, is that 6-second strip method that we talked about. And what we do in that method is we count the number of QRS complexes that we see in that 6 seconds, and we multiply it by 10. Now, a lot of times students ask me, why do you pick QRS complexes? Why don't you pick P waves? Because QRSs are evident. You guys know when you see that big blip on the map that something's going on with the heart. It is beating. It is doing what it needs to do. So for me and my eyes, it's much easier to see that QRS complex. All right, so here we go. The QRS complex, let's see. Get back to the markers here. Go back to the red. Right here, that's one. Right here, that's another one. So you count these in this in the 6 seconds, which are 30 big blocks. We have 1, 2, 3, 4, 5, 6, 7, 8, 9. Okay, we do not count this one. It is outside of our 30 block window. Okay, that's the other thing. You need to determine whenever you're looking at a rhythm strip, you determine the start and you determine the end point. Okay, and that is only what you look at. You look at start to finish here. So that 90 times 10 gives us approximately a heart rate of around 90 beats per minute. We know that normal is 60 to 100. Bradycardia would be anything less than 60, and tachycardia would be anything greater than 100. So now we determine whether the rhythm is regular or not. So we assess atrial regularity. So that's looking to make sure the P waves come every so often when they're supposed to. Or again, you can use the big ventricular, which would be that big R wave that occurs right in the middle of the QRS complex. If your patient has a regular normal heartbeat, this doesn't matter. It doesn't matter if you pick P waves or you pick QRSs, okay? The only time it becomes important is if your patient has a bad, irregular, or abnormal heart rate. I hate to use the word bad, but some of these rhythm strips that you see, there's no other way to describe them but bad. So we'll take a look at these. All right, so typically we look right here, you see this one is measuring between the two R's because it's just easier. In my opinion, it's just easier. And how we determine whether this is regular or not is I count how many big blocks I see between these 2 points. Okay, so I see one full one here. I see one full one there. I see a partial one here and a partial one there. So what I would say is this is about 3 blocks long. So then I go again, 1, 2, 3. Yes, 1, 2, 3, and just a little bit, but that's not enough to call it irregular, guys, okay? So regularity would be within half of a big block. Okay, so for our purposes here, this is regular because there's still about 3 big blocks. Here we go again. This is part of 1, 1, 2, part of 1, 3. 1, 2, 3, 1, 2, 3. So I would say this rhythm is regular. If it's irregular, you're going to see maybe 3 blocks between this one, but only 1 block between these two. 3 blocks, 6 blocks, 2 blocks. So you'll see a difference here in just a minute. So here's where I talk about irregularity. Let me erase these. And you'll see for this patient, 1, 2, 3.5 blocks between these, but then there's only 2.5 between this one. Now we're back up to 3 blocks in between. This one has 4 blocks in between. This one has 3.5 blocks in between. Okay, there's really no regularity at it at all. Okay, this one is actually called atrial fibrillation, which I'm not teaching you here today, but it does have a good example of what an irregular heartbeat looks like. All right, let's take a look at this P wave. So what we have to ask ourselves is there a P wave present? That's a yes or no question. The second thing, do they occur regularly like they're supposed to? I call it like a relationship, right? So you have partner A and you have partner B. Well, partner A should be your P wave. Partner B is your QRS complex. So we need to make sure that there is a partner A that goes along with the partner B almost every time. And that's to this point, which is there one P for every QRS? Are they smooth, rounded, upright? Are they peaked? Either way, no matter what the answer is, it should always come down to, do they look the same? Okay, which is what that one's asking you. So for this one, you can check this one out. They come right before a QRS. They are present. They appear to be very regular in between the P's. They're all smooth, round, and upright, and they look relatively similar. All right, for here, let's take a look at this. Uh-oh, I think that might be a U wave hanging out there. Not 100% sure. Let's take a look. There's a P wave, but no QRS. There's a P wave and a QRS. So this can either be a P or a T wave. I'm not 100%, or a U wave or P wave. I'm starting to think it's an extra P wave. So P, no QRS. P, no QRS. This is a very irregular rhythm. Okay, this is an abnormal rhythm. This is not something that we expect to see on our patients. All right, next thing we're going to do is measure the PR interval. This is the start of the P wave to the start of the QRS. Remember, again, it's about 0.12, 2.02 seconds. And if you recall, our little blocks are 0.04 seconds. So we're talking about 3 to 5 little blocks. There are two questions that you have to ask yourself about the PR. Number one, is it between this time frame? Is this time frame correct? Is this how long that PR interval is? And is it consistent across the strip? So in looking at this is already marked for you, but you see this particular PR interval is 1, 2, 3 blocks long, okay? So the answer to the first question would be yes, it is 3 blocks long, so it's 0.12. And are they consistent? This one's 1, 2, 3. This one is 1, 2, 3. So I would say yes. So this is a beautiful P wave, comes at regular intervals, comes before every QRS complex. It is measuring the right, and it is constant across the strip. So far, so good. All right, here's another example of one. Let me erase my dots again. Well, maybe the highlighter will work better. Let's see. You can see here that we have 1, 2, 3, 4, 5, 6, 7, 8, 9. Uh-oh. Our PR intervals are now 9 little blocks, which happen to be 0.36 seconds. But the nice thing is, I believe, 3, 4, 5, 6, 7, 8, 9, it's consistent. Okay, so even though it's longer than it should be, which by the way is a indication of heart block, but again, outside of what we want to talk about, it is relatively regular, guys. Okay, it happens every single time. There's 9 blocks between that PR interval. 1, 2, 3, 4, 5, 6, 7, 8, 9. Okay, so it's 9 all the way across this thing. We take a look at this one. Erase all of our ink. We see that this PR is only 1, 2, 3, but this one's 1, 2, 3, 4, 5. Holy cow, what's happening here? 1, 2, 3, 4, 5, 6, 7. Okay, and then whoop, nothing there. Okay, there's nothing there anymore. So this is what's called a first degree or second degree heart block type 1, but again, outside of what we want to talk about. But you can see here, this is definitely, they're not the same. They're not regular, they're not consistent, and they're much longer than what we want them to be. All right, next we're going to measure the QRS duration. Again, that's the start of the QRS to the end of it, so the beginning of the Q to the end of the S. It's between 0.04 and 0.10 seconds. You have two questions you have to ask yourself. That is, are the complexes within the normal time frame? So do they land between 1 to 2.5 blocks? And again, are they consistent throughout the strip? Hopefully you're seeing a pattern here, guys. We were looking at consistency. Is it the same throughout the strip or is it not? All right, so let's take a look at this. We have our QRSs. We've got 1, 2. It's only about 2. 1, 2. 1, 2. And 1, 2. So they are within that time frame because they are 0.08 seconds. Oh, let's go back one. Not quite ready for that one yet. And then are they consistent? So yes, they are falling about the same every single time. So this one is considered normal. Moving on to the next one. This is a very bad situation in case you're wondering, but this is not a good day for people, okay? This is typically ventricular tachycardia. These are all QRSs. They are wide. They are all over the place. You cannot see a P wave at all. You cannot see a T wave at all. All you see is this very large and wide R wave just kind of hanging out doing its own thing. And this is not a good day for this patient. So let's take a look at normal sinus rhythm. This is kind of on the downside of what I want to talk about today. But normal sinus rhythm, again, originates in that sinoatrial node. It has to meet the following criteria. Number one, the atrial and ventricular rates both have to be between 60 and 100 beats per minute. It has to be regular. There has to be a P wave present. I call them pretty present and punctual because they are present. They are on time before each QRS complex. The PR interval should be between that time frame and constant throughout the strip. And the QRS duration, again, is normal and consistent throughout the strip. So this is exactly what normal sinus rhythm looks like. Okay, we can see that our rhythm is rate is 1, 2, 3, 4, 5, 6. So this is a rate of approximately 60 beats per minute. We have 1, 2, 3, 4, 5-ish blocks in between them. So again, 1, 2, 3, 4, and a little bit of that one. 1, 2, 3, 4, 5. So consistently, fairly throughout, consistently, it's 5. Back to the highlighter. All right, our P's are there. They're nice and rounded. They're present. They look pretty regular in occurrence. The PR interval, again, 1, 2, 3. 1, 2, 3. 1, 2, 3. So I can relatively say you can continue to look at it throughout the whole strip, but it's about 3 little tiny blocks, so it's within its time frame. We have a QRS for every P wave, and they're approximately 2 blocks each. Sinus tachycardia, okay, a little bit different. The only thing that's different here, though, is that the rate is fast. You will still find that it's regular. You will still find that our P waves are pretty present and punctual. Now, occasionally, if you get into a very rapid rate like 150, 170, 200, the P waves can be hidden sometimes, so it gets a little tricky in the sinus tachycardia range, but you will have people around that knows what to do in that situation. And the other thing I want to bring up here at this point is never forget to look at your patient. Guys, worst case scenario, look at your patient. If they're doing good, let's keep moving, okay? If they are alert, oriented, pink, with it, then boom, we're good to go. All right, the PR interval would be normal. The QRS complex might be a little narrow, but that's just because of the speed of how fast the heart is beating, but they should be relatively normal, and this is what it looks like. Okay, again, if you counted it all out, it would be fine if you did, but you would find that it's 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12. So approximately a rate of 120. All right, sinus bradycardia, you guessed it, is going to be normal, except for the rate is less than 60 beats per minute. So it's a slow rate, but it's still regular. The P waves, again, pretty present and punctual before each QRS. The PR interval will be normal. The QRX complex will be normal, and it's just a little slow, okay? Based on this particular reading, we have a rate of about 40. If you went ahead, and you can probably eyeball it at this point, but your P waves are present. They have a QRS behind them. You know, the PR interval looks pretty consistent throughout, just in a quick eyeball of this. Your QRS complexes look relatively the same. The only problem is it's a little on the slow side. And that can be normal, guys. It can be somebody that's athletic. They could be on a beta blocker to help with their heart rate and their blood pressure. There's a number of reasons why people are sinus bradycardia. But again, it comes down to, are they symptomatic? If they are not symptomatic, then it is not worrisome, okay? And that is it for that. You guys are doing amazing at this. Oops, we want to discard our annotations here. But, you know, here's the thing. This is just the tip of the iceberg. And the beauty of this is you can go back and you can watch it, you can pause it, you can screenshot it, you can do all kinds of things, but as long as you learn it, okay? If you guys have any questions, please, please, please shoot me a message or an email, and I will be happy to answer them. Otherwise, I will see you next time. Bye, guys.